We're going to move on now to our first talk after lunch on adolescent and young adult oncology. We have two speakers for this talk. The first one is Stacy Sanford, who's an associate professor in the Department of Psychiatry and Behavioral Sciences and the Department of Medical Social Sciences at Northwestern University Feinberg School of Medicine. She works as a licensed clinical health psychologist at the Lurie Cancer Center, providing psychotherapy services to adults of all ages facing cancer. Dr. Sanford has also received pediatric training in psycho-oncology at St. Jude's Children's Research Hospital, and she has expertise in working with the entire developmental spectrum with a special interest in adolescents and young adults. In 2009, Dr. Sanford founded the Adolescent and Young Adult Oncology Working Group at Northwestern University, and she's co-chaired, and she served as co-chair since that time. Dr. Sanford is also the director of the Adolescent and Young Adult Cancer Program. And Dr. Jennifer Reicheck is an attending physician in hematology oncology at the Ann and Robert H. Lurie Children's Hospital of Chicago and director of our STAR program, Survivors Taking Action and Responsibility. As a former social worker, Dr. Reicheck is acutely aware of the way in which the psychosocial atmosphere contributes to the treatment of treatment of cancer in children, adolescents, and young adults. As a physician, she tries to incorporate that view into her treatment of young people with cancer. In research, Dr. Reicheck focuses on the psychosocial effects of cancer diagnosis and treatment on children, adolescents, and young adults, as well as the anthracycline-induced cardiotoxicity. Her primary clinical interests include solid tumors, particularly sarcomas, adolescent and young adult oncology, and survivorship. Thank you.
We're actually doing this a little backwards. I'm Jennifer Reicheck. Stacy will be coming next. Can you guys hear me okay? Okay, awesome. So we are super excited to present to you our experience with an adolescent and young adult oncology program that Stacy and I have been working on since 2009. So it really does take a very long time to get there, and it takes a village to get us there. I realize that we are just after lunch, and that lunch can make people nappy. I might start to do a tap dance if y'all start falling asleep. So I promise that Stacy wouldn't have to do that because I'm the dancer of the group. Let me make sure I can make this work. Okay, so why AYA? What's different about this population? Well, even though the cancer populations most publicized are the little bald kids or older adults, there are about 70,000 adolescent and young adults diagnosed with cancer every year in the USA. And when we say AYAs, we're talking about patients between the ages of 15 and 39. So a large population of people in this room fall into that category, and some of us fall into that category in our hearts. In the AYA population, it is the #1 disease-related cause of death, which is shocking. And it is 7 times more common to have cancer as an AYA than it is for children under 5. Although when you think about the commercials that you see on TV, especially starting around this time, this is not publicized well. There's a very low enrollment on clinical trials by AYAs. Only 10% of 15 to 19-year-olds are enrolled on clinical trials, and only 1 to 2% of 20 to 39-year-olds are enrolled on clinical trials. Additionally, the survival rates for this population have not improved over 30 years, whereas you heard from speakers earlier that the survival rates in adults with cancer have improved drastically. The survival rates in young children have improved exponentially, up to greater than 80% we quote as a cure rate for children with cancer in the United States. That is not the same for adolescents and young adults. And as you can imagine, AYAs have some unique issues that are different from those of their older colleagues or in their younger colleagues. There are issues about reentry into school and the workforce. There are issues with insurance and financial stress. There are issues about sexuality, including issues of body image, dating and relationships, which is a salient piece if some of us who might not really be in that age group think back to it. Parenting, adherence to medication and our trials, and inadequate long-term follow-up, as we've talked about a little bit so far today. Additionally, the referral patterns are interesting because young adults can get diagnosed and treated either at an adult institution or a pediatric institution. And most of the time, the place in which a young adolescent or young adult is treated is based on where they're diagnosed. So if you go into an emergency department in downstate Illinois, the most likely thing to happen is that you will get treated at a community hospital that may or may not have expertise in treating somebody who is a young adult. And that makes a difference. And we'll get into some of this information a little bit further on. So there are lots and lots of components of an AYA's life, and this figure depicts some of the life disruptions that we see in AYA patients with cancer. And we mentioned some of them. We didn't talk about fertility, which is a salient point, peer relations, health behaviors. If you think back to being in college, I didn't have a doctor. I had no idea whether I had health insurance. Self-esteem, if you think about a 15-year-old who's trying to decide who they are in the world, and they're trying to break away from their family with the focus more on their peers, it's quite a burden to be diagnosed with cancer. So lots and lots of things are different in terms of affecting people within this age group. The history of AYA oncology is pretty short. In the 1990s, medical and scientific community in the USA started to recognize that this population might have needs that are different from older adults and younger children. In 2005 and 2006, there was a meeting that happened between the National Cancer Institute and the Lance Armstrong Foundation that was called a Progress Review Group. And they developed some recommendations for improving the outcomes for AYAs with cancer. In 2006, the Livestrong Young Adult Alliance was formed. This was back before Lance got into trouble for doping. In 2012, Livestrong was rebranded and became the Critical Mass Young Adult Alliance, which focused on research, understanding disparities in access to care, healthcare delivery, and outcomes. And then in 2012, the NCCN released its first set of guidelines for AYA oncology. And this is sort of when we knew we had made it, because if the NCCN is talking about it, it means that somebody besides all of the advocates for AYA oncology think it's important. In 2012, Teen Cancer America, which is the US version of Teen Cancer Trust that was started by Roger Daltrey in the UK to fund programs for adolescents and young adults with cancer, started to fund hospitals in the US to create both AYA programs and units to continue advocating for this population. And in 2013, the Institute of Medicine had a workshop titled Identifying and Addressing the Needs of Adolescents and Young Adults with Cancer. Here at Northwestern, Stacy and I started a group in 2009 and have been working fearlessly to try and really promote our program here. I'm happy to say we have a lot to tell you about our program ultimately. Stacy will talk more about that. So again, in 2006, the NCI and Lance Armstrong Foundation put forth an imperative to cancer providers that talked about the AYA population as unique with unique needs that should be identified and taken seriously and taken care of. It talked about the characteristics that distinguish the unique cancer burden in the AYA patient. It provided education, training, and communication to improve awareness, prevention, access, and quality of cancer care for AYAs. It talked about making tools to study the AYA population who had cancer, looking at ensuring excellence in service delivery, and strengthening and promoting advocacy for the AYA patient. The outcomes from this group were that specialized programs that targeted the needs for adolescent and young adults with cancer emerged. The cooperative oncology group, so ECOG, the Eastern Cooperative Oncology Group, which is one of the big ones for adults, and the Children's Oncology Group, which is really the only cooperative group in the US for children, decided to create AYA committees out of this imperative. And again, we talked a little bit about the Lance Armstrong Foundation with the Young Adult Alliance, which then changed to Critical Mass, to ensure advocacy and publicity for the AYA population in cancer. The interesting thing about this organization was it incorporated advocacy groups, patient families, and professionals, both medical professionals and psychosocial professionals, and it was both adult and pediatric professionals and people from multiple different countries. The NCCN guidelines that were created in 2012 were also an attempt to answer the progress review group, and they were intended, as most NCCN guidelines are, to provide specific algorithm-based care for 15 to 19-year-olds with cancer. And the hope was that this would change the lack of progress in survival in the AYA population as compared to the younger and older populations. These guidelines were made with a special emphasis on the psychosocial evaluation and care of this population, understanding that the medical care was important, but for the AYA population, it was equally as important to focus on psychosocial needs. And the ultimate goal of these guidelines were to standardize the care for the AYA population and to help not only academic medical centers like Northwestern, but community hospitals across the country and across the world better take care of AYA patients. And it was also hoping that these guidelines would help enroll more AYA patients on clinical trials, because we know that enrollment on clinical trials is tantamount to improving outcomes. There are multiple categories for the NCCN guidelines. I'm just going to briefly talk about them. You guys are all able to read. So it talks about screening and assessment of the medical situation. They describe a comprehensive assessment of AYA patients, and they delineate things like fertility preservation, contraception, psychosocial assessment, familial risk and genetic screening, and treatment adherence and risk for non-adherence as salient points that should be part of a comprehensive evaluation. They talk about treatment-related issues, both looking at dosing schedule intensifications and toxicity. We know that kids tolerate chemotherapy better than adults, and it's unclear within the AYA population whether they should be treated more like young children or more like older adults in terms of dosing schedules. The push to talk about fertility and endocrine considerations is high in this population. This is a population that is at that important chiasm of from childhood to adulthood, and although they may not be thinking about having families at the time when they're diagnosed with cancer, we know from survivors of cancer in the AYA population that a lack of fertility is one of the things that they regret the most. And so it's really important to do this prior to starting any treatment. We know individual psychosocial considerations may be taken into account. An 18-year-old who is living at home and going to college is very different from an 18-year-old who is married and out in the workforce. We know that psychosocial and behavioral considerations and a relationship evaluation are very important, that socioeconomic issues play highly into the care of an AYA patient, and even that palliative care and end-of-life considerations in somebody in this age group are different. For special consideration, the NCCN suggested that AYA patients be managed by multidisciplinary teams at medical centers who have extensive experience in taking care of them. And this is because many AYAs who are taken care of out in the community are not being able to be enrolled on clinical trials, and community hospitals may not have access to resources like social workers, psychologists, and fertility preservation, which we know are really important in taking comprehensive care of an AYA patient. Additionally, the NCCN guidelines are very clear that they need a comprehensive assessment, like we talked about earlier, with psychosocial issues, fertility preservation, and genetic counseling. The NCCN guidelines also talk about treatment options. If any of you can think about what it might be like to wrangle a 17, 18, 19-year-old to get them to agree to come to a clinic on a regular basis and take medication at home, it's exciting. Sometimes the idea of going to Lollapalooza is more important than the idea of getting your chemotherapy, and you have to be creative at deciding how to give people chemotherapy while not taking away life. And so treatment options are really important to talk about, but not just chemotherapy, but also surgery and radiation therapy, especially if you think about invasive surgery that may alter body image. Additionally, we know that this population, because AYAs feel invincible, are not great at adhering to treatment. So in particular, in adolescent and young adults with leukemia, when they're in the maintenance phase and taking oral chemotherapy at home, it is likely that they are not 100% on target with taking the oral chemotherapy. Their parents can no longer micromanage them, and they feel fine and don't understand why it is important. So to evaluate people for adherence and non-adherence is really important. Additionally, there's a big push right now in both the adult and pediatric cooperative groups to really get AYAs enrolled in clinical trials. We know that, as I said earlier, only 10% of patients aged 15 to 19 and only 2% of patients aged 20 to 25 are enrolled in clinical trials. And this is, the NCCN guidelines relate that lack of enrollment to the lack of progress in survivorship. So these guidelines are clear that AYAs should get age-appropriate care. The issue is, where should that care be? For diseases where it has been proven in clinical trials that pediatric care is better in terms of clinical outcome, the NCCN guidelines suggests that AYAs be taken care in the pediatric setting. Diseases such as ALL, rhabdomyosarcoma, and Ewing sarcoma, for example, have been clearly studied and shown that pediatric protocols have better outcomes than adults. However, AML, Hodgkin's lymphoma, and non-Hodgkin's lymphoma are equivocal, and those patients should be taken care of where the best psychosocial care of them can be taken care of. So if somebody is living on their own with a family, probably the pediatric setting is not the right place. In the Children's Oncology Group, we have a concerted effort to try and enroll patients on clinical trials within the AYA population. We now have this initiative called the Responsible Investigator Network that is partnering with both pediatric and adult providers across the country to try and figure out how to increase enrollment on clinical trials for the AYA population. We have a monthly conference call with pediatric oncologists and our adult partners to try and work through and problem solve in places such as here at Northwestern, where we have 2 hospitals and we're only separated by a street, but the patient care is distinctly separate. In terms of survival, in the 1990s, all of the studies showed that AYAs with cancer had lower improvement in survival. However, recently, David Fryer, who is at CHLA, did a study looking at patients in California and suggested that perhaps the outcomes for this patient population may be better than we are thinking. Overall, he suggested that the AYA patients had a survival improvement that exceeded other age groups, but that was mostly linked to changes in cancers related to HIV and AIDS. Although he does acknowledge that survival disparities are significant when you look at different subsets, particularly taking into account advanced stage disease, racial and ethnic minorities, and low socioeconomic status. And these disparities worsened over time. I'm going to hand it over to Stacy, who's going to talk about our program here. Thank you.
I think Jen just covered about 15 years of international work in record time, so well done. So I'm going to try to whiz through this because I know we're a little short on time, but I'm going to nail down a little bit about what we are doing to address this breadth of needs here at Northwestern. So I'll start by talking a little bit about the infrastructure of our cancer center. So the Robert H. Lurie Comprehensive Cancer Center of Northwestern University is an NCI designated cancer center, was a founding member of or one of the original members of the National Comprehensive Cancer Network. Underneath the Cancer Center, there are lots of different affiliates that fall under that umbrella. The 2 that we're going to be focusing on today are our pediatric setting, which is the Lurie Children's Hospital, and then Northwestern Medicine. More specifically, here in the downtown central region of Northwestern Medicine, we have affiliates in the suburbs too, but the work I'll be describing today is here downtown, and that's our adult cancer center. So real quickly, I'll just highlight our mission and our vision of our program. So our program advocates for adolescent young adults. The aim is to increase awareness, advance clinical research, and provide developmentally appropriate cancer care in line with those NCCN guidelines that Jen highlighted for us earlier. Now, our vision is to be a national leader in the field, and we aim to do this by mobilizing our multidisciplinary team that I'll talk about in a little while, and capitalizing on the world-class resources that we have available for us here at the Lurie Cancer Center. Ultimately, we aim to improve outcomes for adolescent young adults. So I'll describe really quickly what our patient population looks like here at Northwestern. We pulled 12 months of data in both the pediatric setting and the adult setting, and I have tried to summarize that for you today. This is the PEDS data. So we estimated from that 12-month time period that we had close to 80 newly diagnosed cases in the PEDS setting, and you can see that leukemia and lymphoma is our largest subset of patients in the PEDS setting. Depending on which subset of data you look at, we're looking at probably 40% of those new cases are patients within our age range, our adolescent age range, and approximately 40% or more are enrolled on a clinical trial in the pediatric setting, and that's pretty consistent with what we see at other pediatric settings across the country. This is a similar slide for our adult setting, so you can see that the disease groups look different, as you might expect. Our largest subset of young adults in the adult setting is our young women with breast cancer, followed by lymphoma. And our 12-month period we pulled for this data, we've had 535 new cases, and that doesn't include all the return patients and patients already in the system. Now the percentage kind of varies, there's not a perfect denominator for this. So analytic cases are those cases that were diagnosed here at Northwestern, and we have about 5,500 new cases. But if you look at like all cases, it's closer to 15,000, so that's a big difference. So the percent of AYAs varies somewhere between 3 and 10%, which depending on which denominator you use. But nationally, the percentage of AYAs is usually about 5 to 6%. My guess is it's probably somewhere around that there here at Northwestern too. And in this data set, we had 7.3% who were enrolled on a clinical trial. That sounds low compared to the pediatric setting, but that's actually much higher than the average, which is 1 to 2% for young adults. So, just a little extra information. Our young adults are predominantly white and non-Hispanic, and as you can see, the prevalence of diagnoses increases with age, with our largest subset being those patients in their 30s, and most of our patients are privately insured. So, a little bit of history. Jen alluded to this, but early career professionals at Northwestern, basically we started a working group. We had interest in adolescent young adults, and we were like, who's doing this at Northwestern? And people looked at us like we had 3 heads, and like, what is AYA? So we started a multidisciplinary working group, was literally just asking every discipline we could think of people who might be interested in this patient population, sitting down around a table and having a conversation. It was that simple. And that group still meets quarterly. We've been meeting quarterly since 2009. And it includes researchers, and it includes clinicians, including nurses and psychologists and doctors and survivorship specialists and palliative specialists and child life specialists and social workers and pretty much anything you can think of. It's an all-comers volunteer type working group, and we were able to accomplish a lot over the past 10 years. Additionally, we have a patient advisory board for our young adults they've dubbed themselves Board 39. They've even developed their own logo. They're a very active and engaged group of survivors, and they meet quarterly as well. And we have a leadership structure to our patient advisory board, and they participate in our quarterly working groups too, and are involved in those multidisciplinary meetings as well. we developed a subcommittee structure for our working group that was very similar and mirrored what they were doing with what was the Live Strong Young Adult Alliance back then. So there's 3 subcommittees. There's our Standards of Care subcommittee, which is what you imagine it would be, and working towards meeting those NCCN guidelines, our research subcommittee, and our awareness subcommittee. And as you can see, they overlap, but and everybody loves a good Venn diagram, right? But ultimately, the Standards of Care subcommittee is what I'm probably going to focus most on today. There are 5 key standards of care that we focus on: fertility counseling, psychosocial support, health insurance and financial counseling, clinical trials, and surveillance and survivorship care. And I'm going to highlight briefly some of the services and resources we have available to us here at Northwestern to meet those needs. So we're a relatively resource-rich environment here at Northwestern, and we're grateful for that. One of the resources that we're proud to have at our organization is the Oncofertility Consortium. So, that was kind of low-hanging fruit in terms of addressing the fertility needs of our patients. And so in both the adult and the pediatric setting, there are sort of different groups of people who help address these needs, but all of our patients have access to reproductive specialists, and all of our patients and families receive financial counseling. We have financial, I meant fertility. We'll talk about financial in a minute. But our fertility preservation experts, including our navigators, meet with the families. They walk them through the process, explain the options for each individual, and they also work with the medical teams to incorporate fertility preservation in their treatment plan. And they also provide insurance and financial guidance to patients and family, because fertility preservation is expensive and difficult for lots of people to access. So we're grateful for that resource. Multidisciplinary care for psychosocial needs. We could spend an hour on this program, but we have social workers, psychologists, psychiatry, patient education specialists, dietitians for nutrition counseling. In the pediatric setting, we also have child life specialists, a school liaison. They offer art and music therapy. And we also refer and collaborate with nonprofit programs to help meet the myriad psychosocial needs that our patients experience. So, and that we have different providers, but similar services in both the pediatric and the adult setting. Now we'll talk about financial counseling. Both settings have financial counselors to help navigate billing concerns and financial assistance programs that might be available in the different hospitals. Other disciplines, including our social workers, may also work with our patients and their families to identify additional financial resources, like grants, disease-specific grants, or answer questions about insurance, or help them answer questions about disability applications, as well as trying to help access AYA-specific financial resources. So we know that financial toxicity is an issue for pretty much anyone with a diagnosis. And historically, I'll give a shout out to the Anthony Rizzo Foundation. They have helped support families in the pediatric setting with the financial needs that they have during cancer care. But here recently, they developed a fund in our adult cancer center called the Hope 44 Fund to help meet some of the non-medical financial needs that our young adults and their families face. So we're grateful to them for helping support our patients in that way. We're an academic medical center, so clinical trial enrollment and engagement in research is just part of our mission across the board. At any given time, we have approximately 300 clinical trials available and open. This might include therapeutic trials or psychosocial trials, or it might be prevention, early detection studies. And I did include the phone number and the email address if you want to learn more about our clinical trials office. But there's also, on the web, you can search clinical trial databases. There's one in the pediatric setting, and then there's also one for the adult setting, including a mobile app version to search the trials that are available at our center at any given time. And then finally, survivorship. So I think we alluded to the STAR program earlier. Jen is the director of the pediatric setting. So STAR is, just to give you an example of how that works, Let's say you're 17, you've been treated in the pediatric setting, and you're off treatment, you would be followed by the STAR survivorship program in the pediatric setting up to approximately age 25. And then as you age out of that, then you'd be transitioned to the adult setting for our Adult STAR program, where you would be followed annually by a multidisciplinary team forever. So it's an amazing program, an amazing team of professionals. This is currently only available for those patients that were diagnosed before the age of 21. So for our older AYAs, they have access to disease-specific survivorship programming, where they can meet with a survivorship specialist and get a survivorship care plan as well. Okay, so most of that has been available since we really started our working group in 2009. What we did not have was dedicated staff, boots on the ground, to help sort of strategically and standardize the way patients were accessing all these amazing resources that we have here. So, like I said, everything that we've talked about up to now was really sort of existing services or people volunteering their time. And so Jen mentioned Teen Cancer America and the amazing nonprofit that Roger Daltrey and Pete Townsend started. They actually granted us some money in 2018 after developing a relationship with them over about 3 years. And that allowed us to hire dedicated staff to help us expand our program. Now, I say 3 years, that's not TCA's fault. That's us trying to move the Northwestern mountain. These things take time. I should mention that the adult and the pediatric hospitals are distinct entities, so it's kind of like getting two businesses to collaborate in a way. So none of this has been easy, but we're excited to say that we now have a core team of 4. Myself and Jen are the co-directors, and then in our audience we have Jennifer Carrera, who is our clinical navigator. I think you'll get to know her a little bit more during the panel this afternoon. And then Bryn Fowler, our program coordinator, and shout out to her because she helped me put together these slides today. So what is AYA navigation at Northwestern currently? So we just hired our team this year, and we just launched AYA navigation in the adult setting in March. And Jennifer is focused on those patients. The goal here is to bridge the pediatric and the adult setting. So because of that, we're focused on those patients diagnosed between 15 and 30, and on those disease groups most common to childhood. So that's leukemia, lymphoma, sarcoma, and brain tumors. And then we're just this month launching in the pediatric setting. So our clinical navigator's role is ultimately we want to facilitate developmentally appropriate care from a family systems approach. She serves in a consultation liaison with the multidisciplinary teams. She provides resources for helping the family navigate complex health systems, connecting patients with relevant resources, facilitating peer connections, because AYAs often feel out of place, if you're being treated with a bunch of kids, or if you're sitting in the lobby and everybody looks like your grandparent. So that sense of isolation is a big issue for AYAs. So peer connection is really important. And also just developing innovative clinical programs over time. We have to be adaptive. We're learning as we go here. It's a brand new program, brand new system. We don't have a lot of models to learn from. So just to give you an example, in our adult setting, just because we have so many patients and so few resources, referrals are reactive mostly in nature, or triggered. So whereas in the pediatric setting, all newly diagnosed patients are assigned a social worker from the point of diagnosis. So the way our navigator is going to operate in the pediatric setting is probably going to look a lot different than the adult setting. So that first NCCN guideline of providing a comprehensive biopsychosocial assessment at the time of diagnosis is really where we're nailing down in the adult setting, because that hasn't been happening just because we haven't had the bandwidth to do it. So that's what Jennifer's focusing on right now, is connecting with newly diagnosed patients, doing a really thorough assessment, and connecting them with all those amazing resources that I shared with you earlier. And that will probably look completely different in the pediatric setting, so as we continue to roll out there. So some of our current initiatives, as I mentioned, we have our quarterly patient advisory board. We have a monthly AYA support group that our clinical navigator facilitates, which I think we had 13 young adults at our last, maybe 14 young adults at our last meeting. We have a monthly AYA newsletter. We have AYA blogs for young adults that are interested in sharing their stories, again, to help people feel less alone. And then we have networking events too. For example, we just had a ping pong event on Monday. It's not patient education so much as it is that opportunity for people just to get together and see people that look like them. And also we have patient education events, which tend to be, bigger, and we're talking about doing a symposium at some point in the future as well. And then we recently launched social media too as another way to connect with our AYA population. We have future ideas too. We have no shortage of ideas. Online educational videos is something we've talked about. Telephone and remote groups. We have a couple of providers who are planning to launch, for example, a telephone support group for young adults that suffer from GVHD and were coming to the hospitals, maybe not ideal. And we're talking about doing some targeted infusion scheduling. We're probably going to pilot in breast first, where we schedule young women with breast cancer in a shared infusion space, if they choose to do that, where they can be with other young women with breast cancer and while they're receiving treatment. And obviously we want to continue to expand our navigation services to additional disease groups, and then additional older ages over time as well. So we're sort of in our infancy with some of these things. So I wanted to include a slide to just help you guys think about what you can do to advocate for AYAs in our setting. Like I've said, I just summarized 10 years of work with lots of people and lots of resources. It is really like moving a mountain sometimes. And not everybody necessarily works in an environment with as many resources available to them as what we have here. So here's just a few things that you might think about as you advocate for young adults in your setting. The first, for the record, this is not me telling you to send all your patients to Northwestern. That's not what that's meant to be. But it says refer AYA to settings that have AYA experience and offer access to clinical trials. That's directly from the NCCN guidelines. Just think about it. If it's feasible, if you have a young adult, is there a setting where people specialize in AYA that might give that particular patient better outcomes? Educate your team about the unique needs of AYA. Consider starting a multidisciplinary working group. Like I said, doesn't have to be anything complicated, just getting interested people at the table to have a conversation. Usually it's fun for us. In doing that, you'll probably be able to identify who your AYA champions are. And in doing that, you'll also be able to identify your organization's strengths and be able to capitalize on those. And then, of course, provide your AYA with resources for peer connection. Straightforward, lots and lots of resources out there available to patients. Online resources, Lakuta Loft, for example, and Stupa Cancer provide a lot of things that patients, even in the most rural settings, can access. Some of these other organizations provide more like excursions. I'll give a shout out to True North Trek, since David Victorson's our next speaker, and he's the founder of that organization. They take young adults on wilderness treks and treat them mindfulness, and so they do lots of great work. So share these resources with your young patients and support these organizations and the amazing work that they do for this vulnerable population. And so we might have a few minutes for questions. And I did include our program's email address here, so if you want to reach out to us about anything, please do. And you can follow us on social media as well.
Do we have any questions?
Spam.
Out of curiosity, how many of the, do you encounter any
cognitive issues. Well, like I said, it depends on how you define cognitive issues. Most of them will complain of chemo brain. Are you talking about more than that, or?
Yeah, chemo brain is one of them.
Oh yeah, sure.
What were the effects of the ability to attend school or work?
I have a young woman right now who's not at work because of it. But,
Pediatric setting, we see lots of kids who need either individualized education plans or 504 plans to help them get through both high school and college.
yeah,
Sorry, can I follow up?
sure.
You know, in children, I work with adults with cognitive issues that in young adults I know less about. Do you get the sense that it affects their development, or that it's more of a kind of the fully matured brain is impaired, or is it affecting their development?
Well, you're probably more of the expert on this than me. But my understanding is that the brain's still developing up to about 25. So I think it's fair to say for our younger cohort, absolutely. And I think there's lots of data to talk about the late effects on cognition in the pediatric setting. And there's a neuropsychologist actually at the Children's Hospital that you might want to meet. And I think we know less about our older cohort in terms of what the sort of long-term effects are. You know, a lot of people bounce back fine. You know, the patient that I sort of shared as an example, she's also struggling with a lot of anxiety, so that's confounds things. You know, how much of this is, you know, recovery from treatment stuff, and how much is it, you know, symptoms of her anxiety. So, but it looks, I would say it looks more similar, having worked in both settings in my career, I would say it looks more similar to patients in their 30s don't look that much different than patients in their 40s when it comes to the subjective cognitive changes, whereas it's a little bit different in those patients that still have developing brains.
Any other questions?
It appears that the AYAs are treated in different types of settings, so how do you try to capture all patients? Do you kind of actively seek them out, or do you try to refer to you guys?
Yeah, that's a multi-million-dollar question, isn't it? Yeah, you're right, and that's why, like with our navigation service, we've kept it pretty narrow in the beginning because we're trying to figure out that. Actually, right now in the adult setting, we are not relying on referrals because they're just not coming in. So we're actually monitoring the census and have developed we're getting a report for patients if they have a new encounter with one of our oncologists in those disease groups, then our navigator gets that list, and she knows to have that person on their radar, that once diagnosis is confirmed, she should reach out to that family on her own. So that's kind of how we're doing it right now, just because and anybody who's launched some new program or service knows that it takes forever to get the referrals. So yeah. Hey.
In terms of all the programs that are being used for AYAs during and after treatment, you know, looking at the numbers that came through between 2018 and 2019, give me a sense of how many people actually use them that you're capturing, just in terms of
That use the variety of services that we don't have that yet. Mm-mm. We have pulled some initial data just to see how many of our young adults actually saw a social worker during that time period, and what we learned from that is not everybody did. So we definitely have, there's definitely patients that that aren't necessarily being touched because of that reactive referral model.
And it's different across the street, so that all of pediatrics, every young person diagnosed with cancer is seen by a social worker within the first couple of days.
Yeah.
We also advocate strongly for fertility preservation counseling, so everybody who's at risk of being infertile, at least to a moderate degree, has a counseling session with a fertility specialist to talk about fertility preservation. And for our younger kids, that means we're doing tissue fire preservation, tissue fire preservation. And for the older ones, we sometimes talk about allograft harvesting. It's happened as much in the pediatric setting as it does in adults. But it is an option.
It is on our to-do list, though, to reach out to folks like our fertility navigator and some of our other some of the other services to get some data on what the current state is and brainstorm ideas for improvement. So, thanks everybody for listening.